Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome back to Year in Review. As today we focus on new data sets and advances over the past year in the use of PIK3, AKT, and mTOR pathway inhibitors in hormone receptor positive metastatic breast cancer. We have a great faculty today, Dr. Virginia Kaklamani from the UT Health San Antonio MD Anderson Cancer Center in San Antonio, Texas, and Dr. Hope Rugo from the City of Hope Comprehensive Cancer Center in Duarte, California. Today we're here to talk about PIK3, AKT, and mTOR. A lot going on, including an approval yesterday that we'll talk about. Great to be in oncology nowadays. However, we will be today talking about the use of unapproved agents and regimens. So check out the package inserts of the approved agents for more. As with all of our Year in Review series, I met with both of our faculty actually this week, recorded presentations. They're going through many different papers that are relate to this topic. We're not going to talk about every single paper today. We really recommend you check out these talks, all the details of the slides. Today, we're going to try to kind of go take it to the next level and talk a little bit about what the clinical and research implications are of these plethora of studies. So here's where we're heading. I'm going to start out with just a little bit of a warm-up about the San Antonio Breast Cancer Symposium that Dr. Kaklamani is the co-chair of. Then we're going to kind of provide an overview of the whole field right now with emphasis on the 4 approved agents. But then we'll get into more detail about the 3 that are most commonly used right now. And then we'll talk a little bit about a couple new agents, as well as some ongoing clinical trials. But just to take a breath before we start running down the field, so to speak, and incidentally, I know everybody's checking out the, is it over? Looks like Argentina won 2-1. So I know all my neighbors here and in Miami are going to be all excited about the final game, and we can focus on PIK3 and not worry about it, I guess, if that's right. Tell me, is that right? Is it actually over or 1 minute left? So presumably that's it. Anyhow, so I called this first warm-up San Antonio Memories. And, you know, Virginia, I was thinking back to when I just finished my fellowship at the University of Miami quite a few years ago. And who was going to become my mentor, Dr. Chuck Vogel, that you both know, a great breast cancer investigator and clinician. And he said, hey, how about joining me and help me build this breast cancer program? So I joined him, and right around the same time, he said, hey, they're starting this meeting on breast cancer in San Antonio. You want to go with me? And I'm like, yeah, sure. And we were off and running, and of course, after a while, started to do education programs. Virginia, I don't know if I ever told you, we once did an education program at the Comedy Club at the mall next to the San Antonio Marriott, where I've stayed 1 million times now. And actually, this year is going to be our 25th year doing CME at the San Antonio Symposium. It's always such a pleasure. But Virginia, I have so many memories of big papers presented. You know, San Antonio really is a unique conference in my mind in oncology in general. Flashing back to the early 2000s with dose-dense chemotherapy paper Dr. Citron presented. The BCRG adjuvant trastuzumab study without anthracyclines by Dr. Slayman. The ATTACK trial. Michael Baum, of course, looking at anastrozole up front. Oncotype was also presented for the first time. I interviewed Soon Paik the night before he presented it. And in more recent years, some of the big trials that stick out in my mind, Inavo 120 that we're going to talk about today, Patina trial looking at Palbo and HER2-positive disease, Ember 3, and of course the last one, Ladera, looking at giredestrant SERD in the adjuvant setting. And Virginia, one of the things that I've enjoyed the most, I just want to ask both of you any memories or things that stick out in your mind. But always what sticks out in my mind is as we're doing these CME Meet programs, and you know, I get a chance to talk to 15 faculty that are participating in our programs. We're always talking about what's going on, and there's always excitement there. I've heard so many great stories about situations where there's a press release like on Tuesday, and somehow you guys figure out a way to get it presented like in 3 days. So anything stick out in your mind about, I've never seen any other meeting do that, Virginia. Any thoughts about the craziness that happens in the few days right before you get started?
So yeah, this is fun. So Tuesday, it was the first day of SABCS, and I was getting ready to go downtown, and I was looking at Twitter, and all of a sudden I saw the press release for Inava 120, and my next phone call was to our program coordinator, and my second phone call was to Hope, and I said, Hope, I want that study presented. After I got the okay from our program coordinator, so we both started working on it, met with people, and the poor person from the company that had the data made the presentation while she was flying overseas to come to SABCS from England. And so Hope said, well, we need to discuss on who's going to discuss it. And I said, well, there's only one person who can figure out a discussion in a day, and that's you. So you get to discuss it, Hope. So
a lot of sleep. Two nights with no sleep.
So from Tuesday, we got to Friday, and Friday, Komal Javeri was able to present the data, and it was as impressive as we thought it was going to be.
And that started a whole new approach. It started a whole new approach because not only did Virginia was the very first person in an international meeting to do this, right? So really forward thinking. But then everybody else is like, oh, well, we want to do that too. So ASCO started this early thing. That's how we got Serena 6 as an add-on, 7:30 in the morning. And ESMO has done it now. And Virginia repeated the whole approach last year, although I think you had 2 days more notice.
We had a little bit more, yes. But Tina was presented to me on Friday before SABCS, and then we were able to get it presented. I think this is extremely important. Data is moving so quickly, and Neil, you know this better than anyone. This is important for our patients. This data needs to be out there. The FDA needs to review it, and unless it gets presented, it won't get reviewed. And this leads to quicker approval. So this is of benefit to everybody.
Yeah, and when we think about it, in particular, San Antonio, it's 6 months until ASCO, or almost 6 months. So you're getting it theoretically out to the docs, to the FDA, and hopefully patients are going to get it as well. Anyhow, it's just a little bit of the pleasure and enjoyment you get out of being in the CME world, just sort of watching what's going on here. All right, let's get down to business. We're going to talk about our key topic here today. And I just want to start out chatting a little bit. Most people end up using our content while they're driving in the car without slides. So even though we're going to show slides tonight, really I'm here to have a conversation with you. And I'd like you to imagine you're making rounds. The fellowships just started July 1st. You're making rounds with your new fellows, trying to explain this to them without slides. I want to just start out a little bit with your vision about I am going to show some slides just for your reference. Of the mechanisms here. So I want to talk a little bit about what the actual pathways are. To me, I don't get too far beyond upstream and downstream, but whatever way you can embellish it, that'd be great. And then looking at the 4 approved agents, let's just focus on that today. Where in these pathways are they actually having the effect, particularly Gedatolisib is interesting, having impacted 2 different locations. Then we'll get into, again, your brief take on kind of where the indications are fitting in the spectrum and a little bit about where things are heading. And then we'll start back and kind of dive in more deep with each of the agents. But Hope, can you just talk a little bit about the pathways involved and how the various agents affect them and what the alterations are that you see? Because PTEN, you can see deletion also.
Yes, absolutely. And, it's interesting. If you think historically, we started out with everolimus because this was a repurposed drug from the transplant setting, where actually it didn't work all that well in that setting, but we had repurposed everolimus because it was a mTOR inhibitor to use downstream, and we thought that it would be the best drug because you would be hitting everything that, if everything was activated above it, you would get it all by hitting mTOR. So we did a neoadjuvant trial looking for a biomarker, actually looking at specifically biomarkers involved in that downstream pathway, and couldn't find one, interestingly. And of course, subsequently, the randomized phase 3 metastatic trial was positive for progression-free survival, and we were able to manage the mouth sores with a steroid mouthwash. So that was the start. So you've got the downstream. Meanwhile, everybody knew 40% of breast cancers that are HR positive have PIK3CA mutations that are activating, so targeting PI3 kinase was important. So, of course, with the idea that more is better, which we've suffered with in oncology forever, they use the pan-mutant drugs, which are too toxic to be able to be delivered with efficacy. So that died. Then we got alpha-specific agents. So now we have alpelisib. So we got everolimus, we have alpelisib, alpha-specific PI3 kinase inhibitor, except for we then recognize all these toxicities associated with targeting PI3 kinase, hyperglycemia, rash, diarrhea. So then the idea was, well, maybe if you go just downstream of PI3 kinase and target AKT, you could have great efficacy. And Capivasertib is the only approved AKT inhibitor, although there's another one that's shown positive data in the phase 3 setting. And that the idea there is you could target patients who have PI3 kinase mutations, AKT mutations, or abnormalities in PTEN, a tumor suppressor gene. We'll say AKT and PTEN about 5% each in terms of alterations. So that was Capivasertib. And then yesterday, we had a fourth drug approved, Gedatolisib, and this is an IV drug, quite different from the others, that targets both the alpha-specific PI3 kinase as well as mTORC1 and 2. So very effective at targeting both of these ends of the pathway that activates an aggressive cancer that seems to be less endocrine sensitive and have higher ability to invade. So that's where we are with these drugs. Now, we also have big interest in mutant-specific alpha PI3 kinase inhibitors. And there are two drugs being tested in the phase 3 setting, Tersolisib in the first-line setting and Zovagelisib in the second-line setting.
So, Virginia, also, you in your talk, you went through a new target here. Maybe you can talk about the PIK3 receptor mutations. Also, maybe you can talk a little bit about the types of assay, particularly liquid versus tissue. Do you acquire these, et cetera? Can you comment on that as well?
Yeah, absolutely. So it seems from this publication that mutations in the PI3 kinase receptor 1 are also a good target for these PI3 kinase inhibitors. And so when we use Capivasertib or Inavolisib in this setting, at least with preclinical work, those tumors that have these mutations are also going to be suppressed. Now, this is a very small number of patients. Around 3% of patients will have PIK3R1 alterations, but still pretty important to know, and it's increasing a little bit the number of patients that will benefit from these AKT PI3 kinase inhibitors. Now, the issue with the assay, we have a lot of different assays, mostly tissue versus liquid. And the question is, when do you do what? A lot of my colleagues will try to do both assays to make sure that they capture all of these mutations. The bottom line is that in most cases, if there is a presence in the tissue, there will also be a presence in the liquid and so forth. But there are some cases where you can only see it in the tissue or only see it in the liquid. So if we have the luxury to do both, then that would be wonderful.
So we're going to talk about where these agents fit in right now, but I hope this is a slide from your presentation talking about sort of where things are heading with these agents. Maybe you can just sort of summarize some of the key issues here. Another thing, Hope, is the issue of these agents and strategies in HER2-positive disease. We talked about the PTEN study and also triple-negative disease. I've heard cases presented to me from docs in practice where they find alterations in triple negative. They don't know whether it works or not. Any comment about where we're heading in general and whether or not these agents are actually will make their way into HER2 positive or triple negative disease, Hope?
Great question, and has been studied a little bit, but there are issues there. So we'll start with these trials here. So with the success of Inavolisib in the endocrine-resistant population, the next, in Inavo 120 that we talked about earlier, the next, of course, approach was to study this in the endocrine-sensitive disease setting. We don't see a lot of patients who relapse on or within a year of their adjuvant endocrine therapy who also have a PIK3CA mutation. So it has been a small number of patients. So expanding to the endocrine sensitive setting in the first line setting is of great interest. But of course, there was also interest in whether or not targeting AKT would work in that setting. So Capitello 292, which should complete accrual this year, is evaluating Capivasertib, but more in the Inavo 120-like population. So then Gedatolisib, with its really remarkable PFS benefits in the second-line setting in a population of patients, all of whom had been treated with prior CDK4/6 inhibitors, opened Victoria 2, which is currently enrolling. And there are two cohorts, endocrine-sensitive and endocrine-resistant disease, with looking at Gedatolisib in the first-line setting. And the nice thing about, of course, that trial is that you don't need to have a PIK3CA mutation, but patients do need to have a reported value because it's one of the stratification factors, as you would figure out. And then for patients who have a PIK3CA mutation, Tersolisib, which is a drug that has less hyperglycemia and primary toxicity is some liver enzyme elevation, doesn't have a lot of rash. This drug, or even diarrhea, moderate amount of diarrhea, this drug has very nice data in the heavily pretreated setting in patients who have mutations and is being tested in Piccolo 2, although I really think it should be pronounced Piccolo. It's pronounced Piccolo. So Piccolo 2 is a trial which also includes, like Gedatolisib, this endocrine-sensitive and endocrine-resistant disease setting. And, of course, we'd love to see a third arm added onto this trial with the addition of an oral SERD. Since this is a Lilly drug, they could add in an oral SERD, but that's not part of the trial right now. There also is a lot of interest in combining these with all of the different CDK4/6 inhibitors. And so, but ribociclib has proven to be a little bit more of a challenge in these triplets. So we'll see. I mean, these will be part of the trials. And then in the second line setting, the Zovegalisib, which is another new mutant selective alpha-specific PI3 kinase inhibitor, doesn't cause a lot of hyperglycemia. In fact, very, very little rash or diarrhea. It has slight elevations of the creatinine that appear to be rapidly reversible and only in a small percentage. That's being tested against Capivasertib in a head-to-head trial in the second or greater line setting in the ongoing Rediscover trial. So a lot of activity in this area, and that's just the phase 3 trials, much less all the other agents that are being evaluated. You asked, about the second part of your question was about
HER2 and triple negative.
HER2 and triple negative disease. And so what we had actually a Bolero trial, Bolero 4 maybe, where we looked at everolimus in patients with HER2 positive disease. And the trouble was toxicity in the maintenance setting, but there was a suggestion of efficacy. And since then, the problem has been the toxicity issues with these drugs. Inavolisib causes some hyperglycemia. The patients who've been eligible have essentially normal glucose and hemoglobin A1C, but we have trials ongoing now looking at proactive management of hyperglycemia in patients with type 2 diabetes and with prediabetes. So they're testing Inavolisib in Inavo 122, I think, that is evaluating patients like a maintenance approach. So it's exactly like a patina approach. Patients get their induction with Cleopatra. They have to have a PIK3CA mutation. If they do, they can go on Inavo or a placebo. So you can see whether or not patients will have a better maintenance if you target the pathway. And then in triple negative disease, again, the trials that were done were hampered by significant toxicity, so they never went anywhere. But now that we have drugs which seem to be much better tolerated, once we get the results from the phase 3 trials, I think testing these agents in triple negative disease that has PIK3CA mutations, I think it's about 20% of triple negative disease, would be a fascinating next step and great interest.
I was just flashing on when we actually got started as a company. It was based on a video we were able to get funding for hormonal therapy of the 1980s, and we started out with this little sort of Pac-Man thing with tamoxifen, and now very, very different.
I remember those Pac-Man.
And speaking of that, Virginia, I'm kind of wondering if the whole landscape is going to completely change with some of these new agents that you were telling me about. I was asking you, like, with your particularly inside information from San Antonio, but just in general, what are some of the studies out there that we might be seeing even in the next 6 months or a year? And I was very surprised that you were talking about new CDK inhibitors, CDK4, CDK246, and KAT6 inhibitors, which I never even heard about. Any comments on that, and whether or not, maybe even the CDK, the first-line therapy, because CDK is going to be changing someday?
I think it will. It's really amazing if you look at where we were 3-4 years ago in that second line setting after a CDK4/6 inhibitor. We had 2 or 3 agents approved, and that was it. And now we have 6 agents with several more on clinical trials that will likely lead to approval. So the landscape is becoming extremely complicated. I feel that the CDK4 inhibitors are going to be taking over, potentially replacing CDK4/6 inhibitors. And as you mentioned, the triple CDK2/4/6 inhibitors may take over, at least in the resistant setting, to the CDK4/6 inhibitors as well. So I think we're going to be able to extend endocrine therapy treatment by a couple years based on all of these agents, and that will help delay the start of chemotherapy, which is going to be very beneficial for our patients.
All right, well, let's start getting into more depth about some specific agents and a lot of new data that's coming out. And Hope, your talk, you went through a lot of the key studies with Capi as well as Gedatolisib. And maybe you can I'm just going to flip through these. You can check out this in the slide deck that we have in the chat room. I'm just going to go to the list of papers that you went through related to Capi, and ask you, can you just talk a little bit about what's new with Capi? Some of these new data sets have come out, what we've learned about this agent, and kind of where you see things heading.
Great. Yeah, I think, there were 3 different abstracts that we talked about from Capitella 291. So the final overall survival data was presented at ESMO Breast Cancer. There, a lot of us learned that we weren't really powered to look at the mutant population it was like 50% power to detect an overall survival benefit in the mutant population, which I don't think we've ever seen a trial that's positive with 50% power. But they powered the trial for overall survival in the entire population. But as you know, the drug is approved in the mutant population because the results were better there. And when you looked at the non-mutant subset in an unplanned analysis, it didn't seem like there was a PFS benefit. So there was no overall survival difference, but again, really hampered by this. We looked at an subset analysis in the 70% of patients who had CDK4/6 inhibitors, and there it did appear that there was a numeric difference in overall survival, which was quite intriguing. And I think, it's nice now that we're seeing trials with more homogeneously treated patients in the first-line setting. We also allowed chemotherapy, and now the endocrine second-line trials don't allow chemotherapy. So I think that it doesn't negate the benefits of Capivasertib, but it does, I think, highlight the problems in how overall survival is dealt with in phase 3 trials when it's a secondary endpoint, just by the trial design. So then we talked about the Capivasertib and fulvestrant, which could be given in patients who relapsed early, so the endocrine resistant setting in the first line or the second line setting. It didn't make any difference. That was as effective in both groups as you would expect. And then a presentation we waited for a long time that was presented at San Antonio was looking at ctDNA, because as people might or might not recall, we had about 15% of patients, 16%, who had evaluable tissue analyses, so they were an unknown in terms of their mutation status. So the problem with ctDNA, as Virginia commented earlier, is that PTEN, large deletions in PTEN and BRCA for that matter, are not picked up with ctDNA. So they spent a long time trying to optimize the ctDNA analyses for this study. So when we saw it, it showed exactly the same thing. Patients with mutations seemed to benefit, and that was good. And we also looked at the ctDNA dynamics. And as we've now seen in multiple trials, if your ctDNA drops off a lot with the first time you check it after you started treatment, that predicts better outcome in our patients. And that's an interesting thing because we don't know how to change it. We're not promoting changing therapy based on that, but it is an interesting biomarker.
So Virginia, actually Hope said something to me when I met with her. It was actually after I met with you, so I didn't get a chance to ask you, but I want to ask you right now. I think she just sort of alluded to data with Capi in the endocrine-resistant situation. And Hope, tell me if I'm quoting you correctly, which is if you have a patient who relapses for example, while they're on adjuvant AI, theoretically they could be eligible for Inavo, but they'd have to have a PIK3 mutation. And what Hope was saying was that now we have data with Capi in that situation. And if they have, tell me if I'm understanding this correctly, Hope, so another AKT PTEN alteration, but not PIK3, that would be a situation where, I mean, would you actually use Capivasertib? So I'll ask Hope afterwards, but any thoughts about that scenario of, it would really be kind of first line, I guess, endocrine therapy or metastatic disease using Capi? Any thoughts about that, Virginia?
Yeah, as Hope alluded or actually mentioned previously, this is going to be a small number of patients that have either an AKT mutation or a PTEN silencing, but it definitely happens. And patients on the Capitella 291 did not necessarily have to have a CDK4/6 inhibitor. So you could use it there. I think my one concern is the fact that we have overall survival data with first-line CDK4/6 inhibitors, whereas we don't have overall survival data with Capivasertib. So I still would probably use the CDK4/6 inhibitor in that first line, but definitely use Capivasertib in the second line after disease progression.
Hope, any thoughts?
I think that, the number of patients is small, and the number of patients in Capitella 291 is small because it was an eligibility criteria for the doublet in patients who relapsed early and were going to go on to fulvestrant. So to me, if you have an AKT mutation or a PTEN deletion, or you're not eligible for Inavo 120, this is a very reasonable approach in the first-line setting. There may be patients who glucose excludes them from Inavo 120, although we certainly try and manage it ahead of time. It can be somewhat challenging. There is, of course, the ongoing Capitella 292 trial, but that's looking at the triplet.
So I also want to get your thoughts about toxicity, but one other thing I wanted to mention that was covered in these data sets that Hope just mentioned, and again, goes into detail in their presentation, that's been an issue out there for the last few years, Virginia, is the patient with a double mutation. So both ESR1 as well as PIK3 AKT. Up until recently, we just had data on double mutations with a SERD, with elacestrant, I believe, and now we see data with Capi, as you might expect. It looks like the same benefit. It's always been kind of an interesting question to ask. We've done surveys and done abstracts on it. But currently, how do you approach the patient with both PIK3 AKT and ESR1, deciding between SERD and Capi, Virginia?
So everybody loves talking about these patients. It's not very rare. Around 20% of patients will have a co-mutation of an ESR1 and PIK3CA. And so when you look at the different trials, they're giving us a median progression-free survival of around 5.5 months, whether we use an oral SERD or whether we use Capivasertib or even Alpelisib combination. So for me, if this is a patient who I feel has still endocrine sensitive disease, does not have exploding disease, does not have a huge tumor burden, I'd rather be using a single agent SERD because it's so much better tolerated. But for a patient that I'm just maybe a little bit more worried, a little more disease, I feel that giving single agent therapy may not be appropriate. I would definitely be using Capivasertib in that setting.
So, Hope, I mentioned that tomorrow we're doing this program here focusing on GU cancers. And one of the studies we're going to talk about is Capi in prostate cancer, where they have a lot of PTEN deficiency, now approved, hormone-sensitive metastatic disease, so much going on with hormone-sensitive metastatic disease. But, we were at the AUA meeting, and the urologists were like, well, how do you give Capi? We actually showed video, I think, of you, Hope, to them in terms of toxicity to kind of get them on board as an emergency, so to speak. But and also you were telling me that you hear different things about toxicity, even from your colleague here in San Antonio, that you find the way you approach it, you really find it a very well-tolerated drug, and other people have issues with hyperglycemia. So Hope, at least in Los Angeles, how do you get a patient prepared for Capi, and how do you prevent and manage the expected toxicities?
Great question. And indeed, there are big differences. I would say, the proactive management is critical, but also the patient population. And my experience, of course, is primarily in San Francisco. Other than LA, it might be different here. It's hard to know. But I went to ODAC, actually, the Oncology Drug Advisory Council, for the Capivasertib for prostate cancer. I learned a lot about prostate cancer, actually, and PTEN deficiency. And then we did this video talking about management of toxicity. I still hear that people have trouble, and I think that it's more that it's not anywhere near as toxic as Alpelisib. But you have to keep in mind that hyperglycemia can occur, and the cutoff was, patients had to have hemoglobin A1C under 8%, but most people were lower than that. And I think, we have these people out in the community who never go on trials who just have totally uncontrolled glucose. Their hemoglobin A1C is always in the 8s or higher. And so I think it's key for those patients to get good glucose control first. And because we're giving this in the second line setting, start early, work with their primary docs. And I think you generally now have to work with endocrinologists. We have the oral agents, and most of these patients end up being on like 3 drugs to maintain their glucose. We have to talk to them about diet and management of diet. And that's important for their glucose control anyway. For patients who have normal glucose, it's important for them to know if they get sick, they have a fever, they don't feel good, they should not take the pill and then call you. Because what we've seen in post-marketing for both Inavo and Capi is that patients who get sick can have DKA and hyperglycemia unexpectedly, even though their glucose was totally normal. So you just lose your normal control. So that education is key. And then you restart and dose reduce. I had a patient who had a high glucose while she was really sick with a viral infection and probably a bacterial infection along with it. And her glucose went into the 400s. We held it, we dose reduced, we put her on an oral drug, and she actually became hypoca. We had to stop the oral drug. She did really well. It was no longer an issue. So then the other 2 issues that people deal with are rash and diarrhea. So, it's a drug that's given 4 days on, 3 days off. So you need to keep that in mind. When I find out from patients, I tell them, make sure you have, your antidiarrheal medication at home. And then when you find out when you get diarrhea. Some people get it on day 4, sometimes on day 5. Some people have like a loose stool once a day. And managing this, understanding what their pattern is. And also what's amazing is you have to tell people that they should only take a half a pill of loperamide. They don't need to take a whole pill. They don't need to take 2. And so, because what people hate is constipation. So it's managing that works. And then the rash I have found is generally pretty self-limited, but I give everybody, based on our work with Alpelisib, non-sedating antihistamine starting the day before they start the Capivasertib, and I tell them to take it twice a day and continue for at least the first 4 weeks. Then if they have no rash, they could go to once a day and then eventually stop. But the twice-a-day dosing really seems to be important, and also starting the day before treatment. It's kind of like getting poison oak the second time in a season. The first time you get a few little spots, and the second time you get it all over. So because your little T cells are all ready for that antigen.
So, Virginia, anything you want to add to that, and particularly the issue of hyperglycemia? I know your population in San Antonio, there's a lot of obesity and diabetes. We've done programs on so many different ophthalmology and oncology. We did a program on hyperglycemia and oncology, incidentally, and had an endocrinologist on there. And one of the things that she was talking about also was the use of GLP-1 drugs, which not only cause weight loss, but actually help in terms of diabetic control. So as Hope was saying, once you kind of are starting to think about this, either involve the endocrinologist or start taking action yourself to try to work on it. But what's been your experience, Virginia?
So my experience, because of the patient population I deal with, 70% of my patients are Hispanic. They have fatty liver. They have at least pre-diabetes, insulin resistance, and so forth, is a little different. These drugs are just hard to give to our patients. And unfortunately, most of our patients are not compliant with diet and exercise, which is why they are pre-diabetic or diabetic to begin with. So it's extremely important for us to understand the geographic variations in the tolerability of drugs. Another amazing example with this class of agents, everolimus, is very difficult to tolerate in Asia. Asian patients have very high rates of stomatitis, even with the use of steroidal mouthwash, whereas with our patients, they do perfectly fine. So I think this is important for our community physicians to understand whatever Hope and I say really affects the patient population that we see and may be a little different in their experience.
So, Hope, as soon as we sat down, we started to get questions on Gedatolisib, particularly with the approval. It is a little bit different, IV drug. Can you talk about how the drug is given, what we know in terms about its tolerability, but also efficacy, and some of the data sets that you went through in your talk?
Absolutely. It's a fascinating drug. And this is actually the data that I contributed to when we did the phase 1B and then 2 expansion. And we had first done Gedatolisib with letrozole or fulvestrant, and then we had the 3-drug regimen. And then they moved and did an additional data set in patients who hadn't had prior treatment in the first-line setting and showed this really remarkable response rate of almost 80% in these patients and a very long PFS. I mean, it's interesting. Now, remember that these patients had not had prior CDK4/6 inhibitors, but still 48.4 months, very encouraging. So this data, of course, we now have Victoria 2, but Victoria 1 is the study that looked at giving Gedatolisib with palbo and fulvestrant versus fulvestrant, and then Gedatolisib with fulvestrant without the triplet compared to fulvestrant. And that study 1 showed a remarkable improvement in progression-free survival with both the triplet and the doublet arms. And then additional data from study 1, as you can see here, looked at time on prior therapy, whether or not patients had bone-only versus non-bone-only disease. And for both the doublet and triplet, Gedatolisib added tremendous benefit for the treatment. I think the concerns have been, the efficacy is remarkable, and all patients had prior CDK4/6 inhibitors. They also had some patients who had early relapse, so, more primary endocrine resistance in the first-line metastatic setting. But there was concern about both the fact that you have to give it IV 3 weeks out of every 4 weeks, although it doesn't cause, issues with problems with veins. It's not a vein irritant. But it was stomatitis, where the rate of grade 3 stomatitis was 19% in the triplet arm in study 1 and 12% with the doublet in study 1. So they also presented some data at ESMO Breast and at San Antonio last year looking at the stomatitis, and you can see that when they look overall at all grades and median time to onset, it all happens within a week or so, or a little bit shorter. It's an early event. And it lasts for about 2 weeks to a lower grade. The one thing that's, I think, interesting about this is that everybody got a steroid mouthwash. They were all told to use it. What they don't really have data on, and turns out to be hard to get, is that we don't know if people actually used it. You actually have to swish and hold it and spit, and then it does work. The other thing they saw, which I think is encouraging given the stomatitis, is that it was a much longer time to deterioration in quality of life in patients who got Gedatolisib versus those who didn't, both for the triplet and the doublet very similarly. So based on this data, we don't have survival data yet. Yesterday, the U.S. FDA approved the doublet and the triplet for patients with HR-positive disease without a PIK3CA mutation who've had at least one line of endocrine therapy in the metastatic setting. And it's interesting because they don't say here in the first sentence that you have to have had a CDK4/6 inhibitor, but all patients had to have had a CDK4/6 inhibitor, and that should be our standard of care, I think, in treating these patients. And it does show you the data here in the approval, but we've come to see that if you give fulvestrant alone in our current patient population, where we really rely on those CDK4/6 inhibitors in the first-line setting, and a lot more patients are getting ribo, that the PFS for fulvestrant is about 2 months. And that's what you see here. Fulvestrant was 2 months, and you can see 9 and 7 months. I mean, this is a huge difference, and I think clinically important for our patients. But we are going to be struggling with both upfront management of toxicity, low discontinuation rate, which is good, and IV dosing 3 weeks out of every 4 weeks. They're working on a sub-Q formulation, and that's going to be critical.
So before we get into the mutant population that was just presented at ASCO but not yet approved, Virginia, in the wild type population? In what situations are you going to use this, and what situation are you going to use everolimus?
I think this is a great option for patients. As Hope mentioned, the fact that it's IV 3 out of 4 weeks is really limiting for many of our patients that may be living far away and so forth. So I think this is really a discussion with the patient. On the other hand, it's IV, so patients are getting it. So compliance is much easier with an IV agent than it is with an oral agent. So I think there's going to be a subset of patients that will benefit from this approach based on different trials settings, but post-CDK4/6 settings. It seems that the doublet and the triplet Gedatolisib has a little bit of a better efficacy than everolimus does. Again, cross-trial comparisons should not be made, but we always make them.
Question from the chat room, Hope, with or without Palbo?
So actually, it's interesting because there's been some conversations on X, formerly Twitter, about this and who you would give the doublet or triplet to. I think we saw more, we definitely saw more stomatitis and more neutropenia, as you would expect with the triplet, and the doublet worked really well. We don't have survival data yet. So I think in somebody who had more endocrine resistant disease, rapid progression, and I was going to try this, I would try the triplet. In other patients, I think I would be leaning towards using the doublet as a kinder, gentler approach.
So I don't know if this is going to be more or less complicated, but what about in the patients with mutations of Victoria 1 study 2, Hope? Can you talk about what we know and where you think it's going to fit in?
This is cool because before this study, the only trial we had, which was a very good trial that looked at apples and apples rather than apples and broccoli, is this trial, because before that it was only Avera. And what I mean by that is that you're looking at a targeted combination versus a new targeted combination versus just looking at fulvestrant alone, which we know doesn't work well at all with our current treatment approach in the second line setting. So here, the control arm was alpelisib and fulvestrant. So that it's, Capivasertib wasn't ready in time for this and a little complicated because you could go on it with AKT and PTEN deletion. So basically they had a control of alpelisib and fulvestrant. They took the same approach of the triplet and the doublet, but they were sort of banking on the triplet. They're thinking this population really needs a triplet. So they made the randomization 3-3 for the triplet and the alpelisib doublet, and then 1 for the Gedatolisib fulvestrant doublet, which is kind of too bad, I think, because it looked really good. And you can see here that it did look really good. Each experimental arm is compared to alpelisib and fulvestrant, but you've got 50 patients in the doublet and 150 in the triplet. Here you can see the hazard ratios are identical for the doublet and triplet, even though the doublet is powered much less so. And the PFS is almost the same. And it's really really remarkable in terms of these data for the patients. And you can tell that you didn't just, when I looked at this the first time, I thought maybe I just copied the same curve twice because the numbers are the same, but the colors are different. So I figured it must be right. And then, the overall response was higher, both whenever you added Gedatolisib, and the duration of response was also much longer. So you can see that, it's hard to really make a difference in the duration of response with the doublet and the triplet. When we looked at toxicity, I figure this has got to be education. Maybe people were smarter at managing the stomatitis, but 16, 19%, it might not be all that different in terms of numbers in grade 3 stomatitis, with about 2/3 of the patients having any grade, and we know grade 2 matters. 6% had grade 3 with the doublet, but the numbers are small, so you can't really bank on that. We just know it's lower than the triplet. So if you look at alpelisib and fulvestrant, though, the toxicity for everything is higher. Look at hyperglycemia. If you look at the overall rate, 58%, and the grade 3 rate, 14%, and you just scoot over to the left to the Gedatolisib arms, you can see it's like minuscule comparatively. So you're just, have a much easier time with giving Gedatolisib, despite the fact that you've got to manage the stomatitis up front and you have to give it IV. The other thing, we look at is rash. I mentioned before that rash is much less common. Grade 3 is 6.5% versus 15% with alpelisib. And we saw a lot of rash, all grade rash with Capivasertib as well. In the same rate, all grade as alpelisib, but lower grade 3. Here you can see that rash rash is about a quarter of the patients, and lower grade 3. So the other thing I think that bothers my patients a lot is diarrhea with these agents, and the diarrhea rate is very, very low as well. So I think, toxicity-wise it wins, and efficacy-wise it wins.
Yeah, we'll see what happens with the sub-Q formulation. In myeloma, we've seen that really revolutionize the use of anti-CD38 antibodies. So Virginia Hassan in the chat room, going back to what we were talking about before, wants to know, why does Geda work with PIK3 wild type? I'm maybe similar to everolimus, whatever mechanism that is. But another question I think is pretty interesting, how do you choose between Capi and the Gedatolisib?
Yeah, so the reason it works is because it's also an mTOR inhibitor, mTORC1 and mTORC2. So that's why you're seeing the benefit in mutant and wild types as well. And whether to use Capi versus using Gedatolisib, I think, again, you're having an oral drug versus an IV agent. You have an agent that has less hyperglycemia potentially compared to a little more diarrhea and so forth. I think people are really going to be the patients, when you talk to them, they're going to say, I want IV or I want oral. I think it's going to be pretty easy that way. So we, as oncologists, have to present both options to them and let them make a decision. But based on this data, it seems that the efficacy is pretty favorable for Gedatolisib.
So another question from the chat room, Hope, is what about Geda plus an oral SERD? And what about in general, are there other trials looking at other combinations of Capi and oral SERD? What about this idea of combining a SERD with a PIK3 agent, Hope?
So, of course, that's the next frontier. I will say that in the subset analyses of study 1, so that's the PIK3CA wild-type population, in the subsets of Avera, in all of these, if you look at the ESR1 mutant population, it looks the same. So I think, if you look at Avera, it looks the same. PIK3CA mutations don't make a difference. If you look at Gedatolisib, ESR1 mutations didn't make a difference. You still saw the same efficacy by adding the agent. It's like a sledgehammer, so that, you have such an effective agent, so you can still give fulvestrant and see this marked improvement. Are we going to see something better if we can target both of the alterations in this 20% of patients who have alterations in both pathways? I think it remains to be seen. And because of, just pragmatic issues, who makes the drug? Is it approved? And can you give it in combination and make a combined agreement, has really slowed down that analysis. We wanted to look at Camizestrant and Capivasertib, but again, that didn't seem as though that was going to have a future. So that trial did not come about after there was some initial phase 1 data. We never got to open the phase 3 trial. But there is an ongoing trial, the Elevate trial with elacestrant, that's combined with multiple different agents, and the arm that recently closed to accrual that should be presented in the near future is a dose expansion looking at elacestrant and Capivasertib. So that will be really helpful because, to my knowledge, that's going to be one of the largest groups that we have data on where you have an oral SERD and a drug that targets the PI3 kinase pathway.
All right, let's talk a little bit about Inavolisib. We were talking about the Inavo 120 study. And Virginia, maybe you can just sort of update us a little bit on some of the subsequent data that's come out in the Inavo study, what we've learned more about this agent, what your experience is in terms of tolerability, and where you see things heading.
Yeah, absolutely. So first of all, I wanted, because we've talked about diarrhea, but we've also talked about hyperglycemia, and I wanted to go into the little bit the pathway of why is there hyperglycemia with these PI3 kinase inhibitors. And so insulin, when it activates the cell, it activates the PI3 kinase pathway, and that's what gets glucose into the cell. So if we're using a PI3 kinase inhibitor, that means that we're inhibiting the influx of glucose into the cell, which is why there is hyperglycemia. And this is how you can understand that insulin use won't work. That's why we want to use oral agents such as metformin, or we want to use GLP-1s as well, although the studies are ongoing. So that's number one. The Inavolisib data is impressive because of a 6 to 7 month improvement in overall survival, not just progression-free survival. So the use of Inavolisib in that first line in patients that have endocrine-resistant disease, it improves outcomes in a very clinically meaningful way. Now, the other interesting thing is that because this is an endocrine-resistant disease, the control arm, which was the CDK4/6 inhibitor plus fulvestrant, really performed much worse than what your usual control arm does in first-line CDK trials. And so that's important for our clinicians to understand, because people will say, well, why do I want to use a drug that has all of these toxicities? Maybe I should just use a first-line CDK. And sure, you can, but expect a much lower PFS because of this endocrine-resistant patient population. And then other data that was looked at with Inavo was subset analyses on ESR1 mutations, on whether there was ctDNA high with the PIK3CA versus low allele frequency. And the bottom line is it didn't seem to work. Inavo was still very efficacious regardless of whether there was a ESR1 mutation or not, or regardless of whether the allele frequency of PIK3CA was high or low. So that helps us as clinicians in understanding when to use Inavo. As we mentioned previously, the Inavo 123 trial is ongoing that's going to look at the endocrine-sensitive patients, and that, together with trials that are ongoing that are going to help us manage hyperglycemia or prevent hyperglycemia, will help expand the use of Inavo in more patients.
So, Hope, I've always been fascinated by this potential correlation in the use of IOs, the checkpoint inhibitors, between autoimmune toxicity and treatment benefit. There's always been this argument about it. I keep seeing data being presented that there is a correlation. And Virginia, in her talk, actually talked about this paper presented at the ESMO meeting, which seemed to show that people who get hyperglycemia do better from the point of view of efficacy. Any thought? I mean, when you see that, do you think you tell the patient, "Hey, I know we got to deal with this, but maybe it's more likely it's going to work"? I guess one target effect.
Yeah, I mean, it is interesting. I thought that data was a little hard to interpret. I don't know what Virginia's take on it was, that you're taking the drug if you get hyperglycemia. So it's part of that because it's a known effect. I don't know that we can say that having hyperglycemia correlates with a better outcome. We do have really interesting data with immunotherapy and triple negative disease that suggests that patients who get IRAEs, or immune-related adverse events, have a better outcome. And that's been shown in multiple different solid tumors, probably the least well done in breast, but we have some inferential data even from Keynote 355. Here, I think it's interesting. What they really showed was that if you had hyperglycemia, you did just as well with the Inavolisib. As long as you could control the hyperglycemia, those patients still benefited from treatment. So I thought that was the encouraging take-home message for me from that presentation.
Virginia, what about dose of these agents and hyperglycemia? Is there a correlation? Is there a rationale to reduce the dose in patients who are having problems with hyperglycemia?
So there has to be. The most important thing is that patients take the drugs. If they're having so many adverse events that they can't take it, then it's not going to work. So we have to work with these patients. Now, there's not a lot of data with the PI3 kinase inhibitors, but we've seen a lot of data, both in the metastatic and adjuvant setting, with CDK4/6 inhibitors. And dose really doesn't matter as long as the patient takes the drug. So it's important that we work with them. For all of these triplets, what I typically do is I start one drug, then the next, then the next. I don't give all three together. And one of the reasons for that is, even though that might delay my triplet for a month or two, at least I know if there is toxicity, where the toxicity is coming from. And it helps with compliance because the patients are not jumping into a triplet combination with a lot of these issues. And this might be important with Gedatolisib when we start using the triplet as well.
So let's talk about, we mentioned these new agents, and there are probably more, I'm sure, as well. Tersolisib is one that we talked about, as well as LOI. I'm not sure that has a name or not.
That is Tersolisib.
Zovegalisib. Sorry, apologize for my pronunciation. It takes me a while to pick these things up, but anyhow, what's the bottom line? Is there a potential advantage either in terms of toxicity or efficacy, Hope, and where do you see these heading?
Yeah, I mean, I think both drugs have offered us a really exciting new path forward. So Tersolisib and Zovegalisib seem to have really reduced toxicity in the areas that we've thought of as, sort of mandatory as part of targeting PI3 kinase, and that's hyperglycemia. Both are low. I think Zovegalisib has the least amount of hyperglycemia. Tersolisib a little bit more, but nothing like what we've seen with, for example, Alpelisib. But still, they are managing the hyperglycemia, monitoring it. We don't see a lot of rash and we don't see a lot of diarrhea. So these are really good toxicity findings from the studies. As I mentioned a little bit earlier, Tersolisib has been found to have some elevation in liver enzymes, but rapidly return to normal with stopping. And Zovegalisib, slight increase in creatinine that also improves rapidly. It's not really clear that it affects actual renal function. So this is something that's still being investigated, and it wasn't dose limiting. So the drugs are being studied, as we showed here, in two settings, the first line and second line setting, and I think they offer a lot of hope for all of us. They showed, both drugs showed remarkable efficacy in heavily pretreated patients with resistant disease and with multiple mutations. So I think we're all excited about the next steps in targeting PI3 kinase. And so much so that some of these companies are thinking about where they can put the drugs in the early stage setting, which is a big leap,
Yeah, I saw a phase 3 there up front, which is very interesting. So one final issue I'm just kind of curious about, I'll start with you, Virginia, is really the more global question of when to go to second-line endocrine therapy versus chemotherapy or ADC. At this point, I think people are looking at how long patients are on CDK inhibitors or first-line therapy. I'm curious, for practical purposes, how you make that decision. You see a lot of second opinions. You see people jumping to ADCs early, very tempting, of course, particularly with TDXD. Any comments? And we talked before about, fulvestrant having a 2-month, PFS in some situations, so you can understand why people want to kind of change strategies. Any comments, Virginia?
Yeah, so I think for the majority of patients with ER-positive disease, giving second-line therapy is probably what we would be doing and we should be doing. The prior duration of a CDK4/6 inhibitor is extremely important. The median PFS for those first-line trials is 24 to 27 months. So we have to think of what the PFS is for our patients. If we see a patient with a PFS of 6 months, we have to really wonder if this is endocrine sensitive disease or not. Potentially doing another biopsy or a liquid biopsy is important to understand how the disease has evolved within those first 6 months and then make a decision. But this is going to be a very small number of patients. The majority of patients will be on a CDK for at least 18 months, if not more. And then those patients, I personally would want to give second line endocrine therapy, especially since now the options are so many. If they have an ESR1 mutated tumor, they can get an oral SERD, in the future potentially oral SERD combination. If they have a PI3 kinase or AKT mutation, they can get a PIK3CA inhibitor, AKT inhibitor. If not, we have Gedatolisib, we have everolimus. So many options available. It really would be a shame for these patients to jump into chemotherapy.
Final comment on that from Hope?
I agree. I think that we're also going to be faced with something else in the not too distant future, which is patients who've received endocrine therapy and a CDK4/6 inhibitor in the adjuvant setting and have developed recurrent disease. And I'm already starting to see some of these patients in clinic where they unfortunately have ctDNA monitored, and then it goes up, and the first thing you find is a liver met. And the question about what to do with these patients who relapse like more than a year after their CDK4/6 inhibitor and more than a year after their AI is a big question. Are you better off using a triplet type approach or a doublet, using an AI like we've done for quite a long period of time. So I think we're going to learn a lot about this from real world setting and actually from some of the trials that are accruing. And then, it's fascinating that when the trials come out, patients aren't treated the way we treat them now. So the IO trials, nobody got adjuvant IO. In the trials we have now, nobody got adjuvant CDK4/6 inhibitors. So we're going to have to see. And then we're moving all these drugs into the early stage setting. So that's going to be fascinating as well. How aggressive should we be and in what patient population? Because we don't have the markers that tell us who needs treatment and who doesn't.
Yeah, I mean, what are we going to do with people who get adjuvant SERDs and CDK inhibitors when and if they relapse? So Hope and Virginia, thank you so much for working with us today. Audience, thank you for attending. Be safe, stay well, and have a great night. Hope, thank you so much. Virginia, thank you.
Subsequent to the recording of this program, the FDA approved Gedatolisib in combination with fulvestrant, with or without palbociclib, for adults with hormone receptor-positive, HER2-negative, locally advanced or metastatic breast cancer, without a PIK3CA mutation following progression on or after treatment, with at least one line of endocrine therapy in the metastatic setting. This approval was based on results from Study 1 of the Victoria 1 trial. Please check out the official prescribing information for more information.